in full disclosure, what I am going to talk about is the work of what other people are doing. I'm the mouthpiece for this. Most of the slides, in fact, come from Laura Rule, who has been the real mover and shaker for Ampath's Population Health Initiative. So if I get things wrong, which I will, that's my problem and my fault. But anything that you learn of value, it comes from Laura Rule and her team, who runs the population health effort there in Kenya. Fair warning. Last evening, I went over the slides that I put together for the first time, and it was in bed with my wife, and she promptly fell asleep. She slept, and unusual for her, she slept all the way through night. And this morning, the first thing she says is, "Man, that was the best sleep I've had in months." This is true story, really is true. So Ampath, the Ampath is an alliance of institutions. It's not a legal entity. Ampath is Moy University, Moy Teaching Referral Hospital, and this consortium of North American academic health sciences centers and universities led by Indiana University. The consortium is inconveniently named the Ampath Consortium. So when I use that term, it means North Americans. When I talk about Ampath, it is this alliance of institutions. And Ampath then collaborates with Kenya's Ministry of Health to effect a healthcare delivery system that now serves a population of about 8 million people. If I was giving this talk a few months ago, I would have said 4 million, but we recently received some additional funding from USAID that then expanded particularly our HIV initiative to a population of about 8 million. We are active in 10 different counties. Actually, I think it's now 12 different counties. And you can think of counties as states. So they call them counties in the United States, but they function like states here in the United States. We say we lead with care. And by leading with care, what I mean is that we hold ourselves accountable to the health of the population. We believe, and I hope you believe, that what good is research if your outcome of research, if your output from research is never translated into meaningful health outcomes and impact on the population? And likewise, if you train the best and the brightest of medical students, which we have at Indiana and we have at Moy University, and they graduate into dysfunctional systems and migrate to the cities or here to the United States, I'm grateful for that they're here taking care of me and my family. But our mission, which is to serve the population, and particularly those with low income, is not accomplished. And so what we say is, let's lead with care and create systems of healthcare, deliberately create them so that they host research and host training, so that at the end of the day, no one of those three missions is any more or any less important than the other two. Now, Bob Dittus, I did the Health Services Research Fellowship years ago. Bob was my mentor. He challenged me to define health one day. I'm going back here to the 70s, right? That's what Bill and I used to wear. When we were in medical school, my wife was in junior high, I think, at that time. But the other point that I wanted to make was that not just that Bob challenged me to define health, but what we're talking about and what Bill and I are going to talk about today is a population health approach. And we'll talk about universal health coverage and universal health care and these sorts of buzzwords. I would suggest to you that most of this is nothing new. It goes back to the 50s and the 60s, 1950s, 1960s. And in fact, for those of you who recall the Declaration of Alma-Ata, which essentially said, we are going to achieve health for all by the year 2000. Well, we're 19 years beyond that. We're not quite there yet. But the key to achieving health for all by the year 2000 was primary health care. And so I would suggest to you that much of what we're doing in population health is just a re-look at primary health care. This comes from the early 80s, this slide, and I love it. Not that I necessarily agree with this depiction of a primary health care system, but it's mostly, in my opinion, got it right. And I guess my challenge to you, and even at the end of my talk, my challenge to you is, if you can come up, you're the engineers and the researchers and the information scientists, if you can come up with a way to determine that when I change, or you or we, Indiana University, Moy University, change one of those cells of this matrix, one of these cells of the matrix, how does it affect all the rest of them? I guarantee you, I will ask my history professors to nominate you for the Nobel Peace Prize. because this has been our challenge. How do we assess and evaluate our population health initiatives? But at any rate, the primary healthcare program elements, the functional infrastructure, importantly, along the side there, you see that we, of course, deliver healthcare across multiple levels of care, starting from home and family all the way up to tertiary care center. And most importantly, but oftentimes missed, is yet the other side of that matrix, which mentions and describes the importance of the community and of intersectoral collaboration. That is, we as healthcare professionals, for example, collaborating with individuals within the agricultural sector. And so, at any rate, I don't want to steal all of Bill's thunder. I haven't seen his presentation, and I had another slide that was going to be something that I think is similar to yours, Bill. But in addition to then trying to create this system that I just described, we, of course, have to be attentive to those factors that truly impact health and those risk factors. And of course, what we in medical school were often taught is that it's not often, still taught, it's the biological factors, the biological, the metabolic, if you will, when in fact it's the social determinants of health, the environmental, the behavioral, the socioeconomic determinants of health that really do impact probably 70 to 80% of the health of any given community and perhaps of all of us as individuals. And so again, as we start to take on this challenge of delivering population health, we need to be attentive to and in fact come up with responses to these particular risk factors. So all roads should lead to universal health coverage. That is the buzzword, the politically correct term, if you will, in 2021. And I think this bears defining so that we're all on the same page. And apologies for reading to you, but universal health coverage is defined as ensuring that all people have access to needed promotive, preventive, curative, and rehabilitative health services of sufficient quality to be effective, while also ensuring that people do not suffer financial hardship when paying for these services. So essentially, it's an integrated healthcare delivery system and the finances to pay for it. Those two together, that's universal health coverage. Well, how did we do it? I think many of you have heard about Ampath. You recognize, I think, that this was started by primary care general internists primarily way back in 1990. And in fact, we were focused on, it was 3 internists and 1 pediatrician who started this program. And what we were focused on was bringing up primary health care. In fact, one of the things that particularly interested us in this partnership with Moy University is that Moy University, one of the pillars of its curriculum was community-based education and service. So from the very get-go, that resonated with those of us who were primary care providers. We got sidetracked, of course. We got sidetracked by the HIV epidemic. But in some ways, that was a good thing because it gave us an entree into developing systems. And so before we engaged in taking on this challenge of HIV, nothing existed in the public sector, hardly anything in the private sector, but certainly nothing in the public sector to meet the challenge of HIV. So we were challenged to create a system from scratch. And I'm not going to go through that. That's another discussion of 60 or 120 minutes anyway. But bottom line, just to convince you, perhaps convince you that we've had some success in this, are listed on the slide here, some of our outputs. So 160,000 HIV individuals, infected individuals, are currently under care within our system. We've enrolled several hundred thousand, of course, over the couple decades. We've been very successful in preventing transmission from mother to child. We're meeting our 90-90-90 goals, and we've developed very successful home-based, community-based programs, home and community-based programs. Importantly, we took on a very comprehensive approach. So we addressed not just, if you will, the medical problem of HIV, but also recognizing that if one's ever going to control HIV, one has to address those social determinants. And so we had very robust programs in food security, income security, programs to address orphans and vulnerable children, and programs to address matters of gender inequity. So we then took all of that and said, and this is about 2009. In about 2009, we said, well, we're successful in creating a HIV treatment and control program. Can we do this with all problems? with all diseases, not just HIV? And the answer is, of course, yes. Well, that's why we're here today. We're trying. And that's what I'll talk a little bit about. So again, just to read to you, to put it all and summarize what I've said so far, the Ampath Ministry of Health system, and all this in the public sector, and working within Ministry of Health facilities, is an integrated model of care delivery aimed at improving outcomes of health and social well-being by comprehensively addressing the biological, social, and structural determinants of health using a community-centered strategy for a defined geographic population. Takes forever to load this next one. Here we go. Now, for those of you who are perhaps less mathematically oriented and are kind of more artsy side of your brain, this is essentially the same depiction of a healthcare system that I put in the matrix in the very beginning. I'm not going to talk much about this except to say that if you all want to understand this program that Indiana University has in Kenya, I encourage you to take a look at this in more detail, and my team can go can spend 4 hours with you on this one slide. But at any rate, the bottom line is that what we're trying to do is tie together all the different silos of any given program, any different health program. You know, you'll see here listed, and I can't hardly read it on my slide here, but comprehensive HIV care, income, food security, non-communicable diseases, et cetera. Tie all those together, if you will, the pipe on top, fasten all this together using fasten it all together, and then water the tree of life here, recognizing that health and wealth are inextricably interlinked. So what's our population health initiative? It's really founded on 3 pillars. I oftentimes say 4 pillars, but pillar 2 here is pillar 2 and pillar 4, and I'll get to that in a little bit. But our pillar 1 is empowering the economic strength of the community that we serve. Not always an easy thing for people who have stethoscopes around their neck to do, but we are doing our best at that. So that's pillar 1. Pillar 2 is creating a seamless care system from village to tertiary care center. This is something that I think would be intuitive to all of you. And then pillar 3 is universal health insurance. Now, what I've shown here, I mentioned to you at the outset that we were in 10 different counties. I've listed those 10 different counties on this slide here, but in that black circle is the county that we're focusing on as our model for bringing up this population health initiative. That county is called the Uasin Gishu County. It has a population of about 1 million people. And in fact, we're not even starting in that county as a whole. We're starting in a turbo sub-county. So in turbo sub-county is where we're really applying our initial efforts. This is an example or a quick profile of the turbo sub-community based on a community survey that we did just recently. And as you can see here, they're saying population at 285,000. It's maybe 200 to 300. It's divided into 6 different wards. Half the people make under $20 per month. It's an important number to keep in mind. Most of them have cell phones. About a third own land. About a tenth went a day last month without anything to eat. And about 30% are involved in some type of microfinance group. It's though there are urban centers, it's very much an agricultural area, and so many of our patients, our clientele, use whatever politically correct word you want here, are coming from a farming community. So pillar 1 then, this idea of empowering the economic strength of the community we serve, is based on this program that we call GISHE. GISHE stands for the Group Integrated Savings for Health and Empowerment. Our discovery of this particular program took multiple years. I won't go through it, but suffice to say that it was, in fact, our Kenyan colleagues who were instrumental in discovering and implementing this program. I should have said at the very outset, when I use the term "we" in virtually everything that I said before now and what I will say for the next 10 minutes, I'm meaning Kenyans and Americans working together. Okay, the Americans here are guests within the Kenyan system. We serve within our respective departments, and we answer to the Kenyan head of department. So when I do use the term we, don't think people that look like me. Think of those who might have a little bit darker complexion than what you see. It's a savings and loan platform for individuals who do not have access to formal financial services. You all want to go get a loan, you go to your bank, you can get a loan. You go to Kenya, 90% of the people walk into their bank and the doors will be closed to them. Or if they do get through, they'll say, there's not a snowball's chance in hell that we'll give you a loan. So most of them come from the informal sector, and this is a way to get loans. The basic elements, and again, I could spend a whole hour on this and I won't. The basic elements of this are community groups, could be mothers, could be farmers, could be community members, could be pregnant mothers, patients with diabetes, you name it. The community groups give the opportunity then for targeted information. It could be on health, it could be on business and agricultural technical expertise, insurance opportunities, etc. It is an opportunity in all of these participate in tabletop lending. So individual community members actually loan to themselves, and they supervise it themselves as well. Pharmacy calling me. I need my Malaron to go to Kenya tomorrow, and so I'll call them later. So that's microfinance is the gist of it. And then it's also an opportunity to link with various farmers groups, Corteva, Dow AgroSciences, and others here in Indiana who have engaged with us to create novel agricultural value chains, co-ops, et cetera. And then, of course, to identify new markets using terms that I didn't even know about, like agricultural value chain, forward delivery contracts. But it's all a very successful program. This is an example of that success. We've had about 1,600 groups formed with, since over the last, 6-7 years. The average savings per member is just about $47. And to you, you think, well, $47, I'll spend that, I'll spend that this evening for dinner. But of course, if you're only earning $300 in a year, $47 is a fair amount of money. And so this is terrific for these folks. We see this as well. We've formed these chamas, these groups of pregnant women who through peer mentoring have improved their own health and their own wealth. And this is again an example of the sort of income that these groups will receive or will make. So pillar 2 is creating the seamless care system from village to tertiary center. I don't need to tell anybody in this room of the importance of the electronic medical record system. And of course, our entire program since 1990, or at least since the year 1998, thank you, Bill Tierney, has been founded on the integrity of the electronic medical record. And I'll say no more about that. There are people in this room who could talk circles around me. We do screening. We don't do comprehensive screening, but we do integrated screening within the community, and screening for things such as diabetes, hypertension, depression, alcohol use disorder, psychosis, cervical and breast cancer, and of course, HIV. And as I mentioned previously, we have the Chama Cha Mama Toto pilot program, which is a peer mentoring program, which also has shown really remarkable success. Deb Litzelman in this room has applied many of the same concepts to rural or impoverished Indiana. And what we've seen here is increase in antenatal clinic visits, increase in facility deliveries. Most folks historically don't deliver, of course, in facilities in Kenya. Increase in breastfeeding, and of course, an increase in a visit by a community health worker, which heretofore had not been existing at all. So again, could go through a whole 2 hours on community health workers, but I'll defer to you, Deb Litzelman, to talk about that both in the United States and in Kenya. We integrate chronic disease, and the notion here was that we could take every HIV care clinic and transition it into a chronic disease clinic. So rather than treating just HIV, these clinics can treat patients with diabetes or hypertension or heart disease, et cetera. To do this, we had to bring up a new cadre of worker, what's called an advanced practice clinical officer. Virtually all, not all, about 95% of healthcare in Kenya is delivered, in the public sector, is delivered by what are called clinical officers, and this is akin to a nurse practitioner. And yet these individuals were not trained in chronic disease care, and so we've created and introduced and accepted by the government of Kenya this new cadre called the Advanced Practice Clinical Officer, created the curriculum, et cetera. These are the individuals who'll be working in those clinics. We've improved the referral mechanisms and have used telecommunications such as the ECHO program, which I'm guessing most of you are familiar with. And again, Deb Witzelman if you needed to talk about it, Deb's your person, she'll do it. In the integrated care delivery system, which is Pillar 2, Pillar 4 is the specialty care, bringing up specialty care. And here again, we brought up a host of specialty care. And most of this actually is on the back of Indiana University, Duke University is one of our partners as well in cardiology. Then Pillar 3, in the 5 minutes that I have remaining here, Pillar 3 is universal health coverage. And one can ask, well, how can we get to the universal health insurance a part of universal health coverage? And for those of you who are Republican in this room, my apologies, but let me read this to you anyway. Although the experience in Africa is still emerging, experience from high-income countries shows that public financing and public regulation of resource allocation, whether the funds are raised through taxes, social insurance contributions, or a mix, is a must if equity is an objective. Private insurance funding arrangements cannot be relied upon as a vehicle for UHC. However, service provision could be public, private, or a mix, and equity objectives could still be obtained. And so Kenya has bought into this notion, and they've developed this thing called the National Hospital Insurance Fund. Now, nobody really knows how, in this country or in Kenya or anywhere else, nobody really knows how to create an insurance package for the poor, if you will, if I could use that term. And so, Ampath is the model, the test case for figuring out how does one incent very low income individuals to purchase and stay enrolled in an insurance package that costs, say, $5 per month, which this insurance package costs. $5 per month for a family of 5 is all that this costs. But again, 5 times 12 is 60, and if you're making just $300 or $400, that's a lot of money. So figuring out how to do that is what we are engaged in. And so we've created through the National Hospital, or working with the National Hospital Insurance Fund, a concept similar to what you're used to here we are used to here in the United States, creating a primary care network and provider accreditation. The cost, it's a capitated cost, money then flows into that primary care network. Inpatient costs are covered, but in fact reimbursed by another source, and so it's a wonderful package on the part of the government of Kenya. And then in order to incent deliveries in facilities, the primary care network receives an extra 10,000 shillings, or if you will, $100 for every facility delivery. I'm just gonna go here, 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 and here. We're in the very early stages of doing this, and it's just the stuff to the right of the screen that I'd encourage you to focus on. Basically, we're canvassing the community, going door to door, figuring out who's already enrolled in National Hospital Insurance Fund, and if you're not enrolled, do you want to get enrolled in the National Hospital Insurance Fund? And bottom line, given the time here, is that when we first went out, about 22% of households, these are households, had National Hospital Insurance Fund. And at the end of these 11 weeks, after canvassing 6,400 households, about 30,000 people, we were able to increase that from 22% up to 51%. And if one looked at those who couldn't right then afford it, but were still engaged with us in looking at ways to get to the point where they could, through Guichet and others, get to afford this insurance. We are in fact at 87%. So from 22% up to 87%, and you turn around and you walk out the door and you just see yourself patting yourself on the back, right? You say, wow, what a great job. But we learned some other lessons. Households, unfortunately, don't equate to individuals. And for my wife to be enrolled, if I was a Kenyan, enrolled in National Hospital Insurance Fund, I have to produce her marriage certificate. Well, 50% of the people don't have marriage certificates. And for my kid to be enrolled, I have to produce the birth certificate. Well, 50% of the kids don't have birth certificates. And so we're stuck there. All sorts of issues with registration, which I'm guessing makes you almost ecstatic at the Regenstrief. You know, how do we make registration work? But no, not a lot of ecstasy out in the room right now. I'm thinking of my wife. Okay. Folks default. These are farmers. You know, they have a good month for 10 months, and then they have a lousy month. They're out of money for 1 month. They can't make their payment. They're screwed. And then they can't enroll again. They're penalized for National Hospital Insurance Fund. So this is a big challenge. And of course, any bureaucracy run by the government, any program run by the government is going to have some element of a bureaucracy, and that's its challenge as well. So 22%, now we're down to 30%. We got 70% to go. It's not quite as good as we'd hoped, but we're learning. Assessing this whole system, evaluating it, again, gets me back to the matrix. For those of you, if anyone here in this room can figure out how to do that, I forgot to say, Megan Miller, who's the Associate Director of the Center for Global Health, who is standing here in the back, Miriam Barr, and Nicole McCollum, who run the money of the Center for Global Health. They will give you, I promise you, $100,000 to start right now if you can convince us that you know how to assess this population health initiative. Because right now that money is going to Johns Hopkins, and I think it's a tragedy that we're doing that. But that's the truth. And finally, with just 15 seconds to go, this again encapsulates what it is that we're trying to do, recognizing that health and wealth, again, are inextricably linked, going door to door, promoting insurance, getting folks to buy insurance, figuring out how to make this whole package work, empowering the community through community groups, doing comprehensive, really integrated screening, creating the quality primary care system, the referral to specialty services, and then the circle repeats. So with that, I'll turn it over to my colleague, Bill, whom you all know very well. Thanks.